Welcome everybody to post-grand rounds interview with Dr. Robert Hedaya, who's a clinical professor of psychiatry at Georgetown University Medical School and a renowned psychiatrist in the field of applying the model of functional medicine and systems thinking to psychiatry and sort of breaking apart our traditional notions of why mental illness occurs and how to deal with the root causes of it. In fact, it kind of reminded me after listening to his grand rounds at Cleveland Clinic today about a conversation I had with Thomas Insel, who, when I asked him about the DSM-5 or the DSM-4 at the time, he said he thought it had 100% accuracy and 0% validity, meaning it was very accurate in describing the symptoms and categorizing people according to their symptoms of mental illness, but not valid because it didn't describe the root causes or the etiology. And I think we just heard today from Dr. Hedaya about a variety of factors that are driving mental illness, particularly depression, but I think it applies across the spectrum of mental illness, including nutritional factors, hormonal factors, immunological factors, gut microbiome factors. He alluded to the role of environmental toxins in mental illness, and all of these factors are fairly ignored when looking at mental illness. And I think I just want to really welcome you, Dr. Hedaya, to Cleveland Clinic, to Grand Rounds here in Cleveland Clinic, and to sort of help us to understand the role of functional medicine and psychiatry. And years ago I wrote a book called The Ultramind Solution, which was about how the body affects the brain. And traditional psychiatrists have typically think of the brain as in the head and the mind as something that's sort of sitting on the top of your shoulders, it's disconnected and unrelated through the blood-brain barrier. But as we now know, there are a variety of factors that are going on all the time that can be modified. And you presented some very compelling stories and cases of patients who had really treatment-resistant depression and symptoms that were relatively easily modified through some simple application of functional medicine. So tell us how you got into this, and how did you kind of first come to figure out that, psychopharmacology wasn't God's gift to mankind?
Well, it started probably in my internship where I was giving a woman, her potassium was low and I was giving her K-Lite. And I thought, why should I give her K-Lite? Why don't I give her a banana with every meal? And I nearly killed her with 3 bananas a day.
Yeah.
But, really the way it happened is I was treating a woman with panic disorder really early in my practice, and I did all the standard stuff, cognitive behavioral therapy, and then I tried imipramine and that didn't work. And then I tried Xanax, which was new at the time. I was like, this is gonna work, didn't work. And a year into her treatment, she paged me on a Saturday night. I remember I was dancing at a wedding, and we had the beepers back then, and the beeper went off, and I found the phone booth and called her, and she says, I'm having a panic attack. And I'm like, what? I'm missing something here, So I went into the office Monday morning, and I looked at her chart, and I had a CBC, and I saw that her MCV was 101. Now, I was trained, it's a little bit out of the range, just
don't worry about it.
Pay attention to it, right? So I said, maybe B12 deficiency. So I did a Schilling's test, and she came out positive, and I said, all right, B12 for you. In days, her panic was gone. And I was like, whoa, like the head is connected to body by this thing called the neck.
Right.
Right. And it was like, really, what else am I missing? Because in psychiatry, we really used to talk about a revolving door. You'd go into treatment, then you'd leave treatment, then you'd show up at another psychiatrist's office.
Right.
Because the problem wasn't being addressed.
Right.
So I thought, what am I missing? And one thing led to another. You just look for truth.
Right.
Look for what the science says, and that's, you end up in functional medicine.
I mean, it's so fascinating because, most of the time we see someone with panic disorder, we think it's a psychiatric problem. It's some trauma, it's PTSD, it's some psychiatric issue, and sometimes it is, right? Sometimes it is.
Well, you don't separate it.
But, but if you have someone with a massive, life debilitating condition like panic disorder, and you give them B12 and they get better, like what? I mean, I remember a guy came to see me a few years ago who was an executive. He was having severe panic attacks in the afternoon, thought he was having a heart attack, he was short of breath, his palpitations, he couldn't breathe, he was anxious, he thought he was going to die, and it was really debilitating for him every afternoon about 2 or 3 o'clock. And so, what is your lifestyle like? He says, well, I go out at night after work, we drink, we eat late, then I'm not hungry in the morning, I don't eat all day, I'm working, and then like at these things at 2 o'clock in the afternoon, I'm like, well, he was insulin resistant, he got hypoglycemic, he was like, it was his, diet and lifestyle. It was like, just eat breakfast and don't do this, and it's like, it went away. It wasn't that hard, but if you listen to people's stories, you can often find the clues.
Well, the trick, the key is, you think, this woman that I'm telling you about, she was 50 years old, she had a bad marriage, her only child was going off to school. I thought she had panic because she was thinking about separating.
Right.
That's what I thought. That was my working hypothesis, right?
We attach meaning to psychiatric disorders that often is a mistake.
Right.
And I think this is really one of the fundamental flaws of psychiatry, is that we have these myths and metaphors for why we think people are mentally ill.
Right.
And now we call it a neurochemical imbalance, and it's psychopharmacology, but I remember reading a book called Madness and Civilization when I was in college about the varieties of perception around mental illness over the ages. It was, it was being inhabited by angels, or been inhabited by devils, or by, there was a different time.
Exorcism.
It was by, sage, it's like it was a revered condition in certain cultures, and other times they were just locked away and treated as witches or whatever,
That's right.
And so we have a very, clinical version of it. And I think the thing that I want to sort of dig into with you is when you were talking in your lecture about inflammation and depression. It's not something most psychiatrists think about. How is the brain inflamed, and how could that lead to brain dysfunction and particularly depression? I've seen this over and over in my practice, where I've seen people who have severe clinical depression, and they tend to have all these other, quote, comorbid inflammatory problems, sinus issues, eczema, food allergies, whatever. And it's stunning when you start to deal with those things, the mental issues go away. So talk to us about some of the research and the information about this, because I once saw a paper that showed that people on TNF-alpha blockers had less depression, right? Right. Or people who take interferon for hepatitis or MS, they get actually more depression because it creates more inflammation.
Right. So the deal is this. I mean, the process is that, first of all, we know there are at least 3 pathways by which inflammation in the body is transmitted to the brain. It could be carrier molecules carrying the inflammatory messages across the blood-brain barrier. It could be through the vagus nerve. There are different pathways, right? So what happens in the brain, though, is when it receives these signals that there's inflammation, is you have activation of the microglia, one of the 2 types of immune cells in the brain, and they release glutamate. And glutamate is obviously a necessary excitatory neurotransmitter. Right?
It's an excitotoxin in a sense.
In high doses, it's toxic, right? So the microglia are putting out more glutamate, and then astroglia are not cleaning it up. And then also what happens is you have this indole dioxygenase enzyme that gets activated by inflammation, and that steals tryptophan, the precursor for serotonin, away from making serotonin to this inflammatory pathway that makes quinolinic acid, which stimulates the NMDA receptors, which release more glutamate. So you have this glutamate storm, and you have a low GABA, and you have high glutamate, and you have low serotonin, and so neurochemically you have inflammation in the brain. It's not that the brain is swelling outside of the skull, but you have microscopic or molecular inflammation in the brain that changes the neurochemistry of the brain dramatically, and you get depression, you get anxiety, you have memory problems, you have sleep problems, and cortisol changes. I mean, there's a whole host of changes that happen within minutes of inflammation, within minutes. And you'll hear this from patients when they eat certain foods. They'll have inflammation, they'll get foggy-headed within minutes. They did a study where they actually infused lipopolysaccharide IV into 20 normal volunteers.
Well, that sounds like fun.
How do you find normal volunteers? I don't know. It's an oxymoron, right? But that's what they did. And they tracked at 3 hours, 6 hours, 9 hours, 10 hours, they tracked interleukin 1, 2, 6, TNF-alpha, cortisol, and what they found is a very tight correlation between anxiety, mood, memory problems, and the cytokines and the cortisol, they were tightly correlated. And these were doses of LPS, lipopolysaccharide, that were not enough to make these participants feel sick.
Right. It's typically what you'd get if you have a leaky gut, right?
It's even less than that.
Even less.
So
right.
if you have a leaky gut, you're getting a massive
Yeah.
antigenic assault,
Yeah.
right? And that has a big effect on the brain.
So in terms of the inflammation, is it working by interrupting enzymes, or is it working by just activating the microglia, or
Well, so it's activating this 2,3-indole dioxygenase, right? IDO, right? Which shunts the tryptophan down a different pathway.
You can measure that on organic acid with quinolinate.
Quinolate, kynurenic acid, and quinolinate. You can measure that organic acids. And you have, if you measure, you'll see markers of serotonin 5-HIAA. That'll be lower. If you measure melatonin, which comes from serotonin, that will be lower. So basically, you've had switching
people with
stations.
inflammation have sleep issues.
That's right.
Right.
That's exactly right, and they'll be low in melatonin. They won't be. They'll be anxious because serotonin will be low. There's an inverse relationship with serotonin and dopamine. So when serotonin goes low, the dopaminergic pathways actually get activated. So now you're kind of between the glutamate and the dopamine, you're kind of activated and anxious, overstimulated. You can't sleep, you know, and you'll have more anxiety, more OCD, more depression.
So how would you sort of address people with that sort of inflammatory depression?
So the first quick thing to do is maybe give some 5-HTP, not tryptophan, but 5-HTP, just so they can get something going down that 5-HTP serotonin pathway, right? Melatonin. But the key thing is get to the source of the inflammation. Where is the inflammation coming from? That's what you got to know. You got to get some markers. You know, look at the CRP or the SED rate or the C4A or C3.
So in clinical practice, what are the top 3 things that are driving inflammation in this patients with depression?
What I see is infection. I see foods.
Like food sensitivities?
Food sensitivities,
gluten.
yeah, IgG type of food sensitivities. Gluten's huge. I would say all grains. Really, we now know that it's not even gluten, but just wheat in general and all grains. People have sensitivities. We don't necessarily fully understand exactly why, but they do.
Could it be lectins or could it be?
Yeah, it could be lectins. I mean, so the diet is number one, right? And I'd say infection is.
Is it also not just the food sensitivities, but is it the macronutrient composition and
also
glycemic index of foods?
Right. Exactly.
The fats. I mean, all these macronutrients play a role, right?
That's right. That's right. We know that what I see is very interesting in clinical practice. If you're talking about macronutrients, just on a day-to-day basis, and this is a useful thing to know. When people come in and say, my mood is bouncing all over the place, and so you ask, well, what do you mean? Is it within the day, or is it, you know, over the course of the week?
Yeah.
If it's within the day, you know it's macronutrients, right?
Yeah.
You know that they're not maintaining glycemic balance, right? And it's very simple to deal with. You just help them, educate them on appropriate diet, and you'll have more mood stability. And of course, the downstream effects of adequate fiber and a well-balanced diet and good micronutrients and macronutrients, it affects the whole body. Right?
So you've got the macronutrients, you've got food sensitivities around food, and the next thing for inflammation is infections.
Right.
What are you talking about?
It could be anything from periodontal disease. What I see actually is I'll see Lyme, I'll see Babesia, Bartonella. Sometimes I'll see parasitic infections, Candida. Sinusitis, very common. Chronic sinusitis, very, very common.
There are a lot of neuropsych reactions to tick-borne infections, which is often missed and overlooked.
Yeah.
I just had a patient who had a lot of cognitive issues and depression, and he turned out he had very high titers of IgM to Ehrlichia, which had been overlooked.
Right.
And
it's very common.
If you don't know how to be an inflammologist, right, and go down the rabbit holes of what the clinical history and also physical diagnostic lab tests for inflammation, you often miss these things.
That's right. So you start out by taking a good history and you can pick that up, but Lyme disease is epidemic, and of course the tick carries other diseases as well, so we have to be well versed in that. So it's not about treating the symptom of inflammation with NSAIDs, you know, right?
Well, I read something on biologics. The patients who are on biologics have less depression.
That's right.
And then they're like, well, we should use, you know, Humira for depression. What a concept.
Yeah, yeah, it's kind of scary because every study, that's what they say. This indicates that there are new targets for drug use in depression, and it's like, thank you, we have enough. Let's get to the source. You know? So
you're saying basically macronutrient balance to balance the glycemic load index of the diet. We didn't talk about fats, we can get into that in a minute. Dealing with food sensitivities, particularly gluten, and dealing with inflammation from infections, also food sensitivities. What other things besides infection?
A lot of things that cause inflammation. Stress causes inflammation. Sleep deprivation causes inflammation. Sedentary lifestyle causes inflammation. Mold causes inflammation. Toxins in your environment cause inflammation.
Yeah.
All right. I mean, there's a long list of things that cause inflammation.
It's actually a relatively short list. It's toxins, microbes, allergens, poor diet, stress, right?
Sleep deprivation.
Sleep deprivation.
You know, traveling across time zones repeatedly as part of your lifestyle.
Yeah.
I mean, it's...
Other stresses, right?
Depends how you
I always say
break it down.
stresses are in that like category of the stresses of lack of sleep, the stresses of lack of exercise, the stresses of time zone travel. Those are all various forms of like, you know, allostatic load on the system.
Right.
So then the third thing you said, besides infections and inflammation and the food, what's the third major thing you see as a driver? Hormonal issues?
Hormones would be there, but probably stress.
Stress.
Probably stress, because that's ubiquitous, you know. It's not that hormonal issues are not present in depression. I mean, they're all over the place. I mean, I don't really find too many patients with depression who don't have hormonal issues. But if you're talking about, I don't think of, maybe when it comes to glucoregulation, I mean, I think about inflammation there, you know, but I think of inflammation really coming, much of it from stress, you know.
Interesting, you know, I was just at a conference with Deepak Chopra, we're talking about the effects of meditation and the research they're doing, looking at its effect on gene expression and cytokines and a whole host of things. And, you know, Dan Harris, who's on Nightline, who's a TV reporter personality, he was on live television in front of millions of people, I think it was the Today Show or something, and he had a full-blown panic attack. Then he started, then he started meditating, and it changed his life. And he wrote a book called 10% Happier. You know, And I used to meditate quite a bit, and then I sort of stopped for many years, and I restarted recently, and I noticed that, you know, even amidst all the various things I'm doing and the stress, that my level of anxiety went way down. I didn't even know I was anxious. My energy improved, and my mood improved, even though I didn't think I was depressed or sad, but my outlook and my mood has dramatically improved just by a simple technique, which is 20 minutes twice a day. And I think we underestimate the power of these things on us.
Meditation is interesting because people hear it and they go, whoa, meditation.
Can't do it, right?
Yeah, I don't know what that is. And then there are so many techniques, but so simple.
It's so easy.
So simple, and I have found the same thing, that it actually reorients your attitude about life.
Yeah,
you know?
It's like effortless, right?
You know, after I started meditating, my wife and I were having a conversation, and she said something, whatever it was, and I just paused, and she says, "You were doing a little meditation there, weren't you?" Because I didn't.
You close your eyes and go la 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 la.
No, meditation's fabulous, but you know, engaging in exercise that you enjoy, or hobbies, or I mean, a lot of things. There are many things to do.
Okay, so let's talk about my favorite topic is fat and the brain and depression. So in your talk, you emphasized the role of EPA as an omega-3 fat that was more beneficial than DHA. And you know, we often hear that like DHA is better for the brain because most of the brain is made up of DHA. It's important for ADD, for intellectual development, for dementia. So why is EPA more effective for depression?
The truth is, I can't answer that. I mean, I wonder if it has. I'm sure you do. That's why you asked me the question. But I've read about it having anti-inflammatory effects, of course. But it is clear that that's more effective for depression, and DHA actually has obviously other roles to fill critical, really. But so I'd like to hear from you.
I think it's what you were saying. I think it two things I think are important. One is it regulates inflammation; it's more anti-inflammatory, and second is that it activates PPAR, these nuclear receptors that are regulating inflammation, that are regulating insulin resistance and insulin sensitivity, and it may have an impact on that as well.
That makes sense.
And and then you mentioned something in your lecture which I sort of question, which is that that we've seen bad diets increase, including saturated fat, which may be linked to depression. And from first of all, just in terms of the data, our intake of saturated fat has gone down. Our intake of beef, tallow, lard, and butter has gone down by 50% over the last 100 years. And our intake of omega-6 refined vegetable oils like corn oil, soybean oil, canola have gone up by 40%. And there's really good research from Dr. Hibble and his group at NIH around the increasing use of omega-6s in processed food in the food supply that have been linked to suicide, homicide, violence, depression. And I wonder if you sort of have any thoughts about that.
Well, I know, maybe you know Dr. Borscano, he gives a good lecture on omega-6s and violence. So there is data about that. So I wasn't meaning to imply that saturated fat consumption itself went up, but I was really talking about the general American diet, which is really definitely much worse now certainly than it was when I grew up. But I think what you're saying is true about the omega-6s. I see that in many of my patients when I measure their omega fatty acids, RBC, EFA, I see the omega-6s are high. I think that's right. And they're pro-inflammatory, right?
So macronutrients, sugar, the fats you eat. What about protein quality? How does that play a role in depression?
Well, I think you need to have a broad type of protein intake. I'm a little concerned that a lot of people rely on these, well, maybe not across America, but there are groups of people who rely on protein shakes. And I think that's fine here and there, but you want a broad array of proteins. So you want some animal protein, you want some fish protein, you want various types of proteins because they all have different amino acid balances. So I think that's important.
Yeah, and what about the role of toxins? Because we didn't have a chance to go through it in the grand rounds, but my experience is that people who have heavy metals, including myself, when I had heavy metal toxicity, I noticed huge impacts on my mood, my sleep, anxiety, stress, and I've seen many patients who had treatment-resistant depression or psychiatric illnesses.
So toxins are huge. So if we talk a little bit about mercury, for example, there's University of Calgary has a great video. If you Google neurotoxin mercury, University of Calgary, you'll see a video that shows how mercury actually disrupts tubulin and the ability to make new neurons. That mercury has been known for years to cause psychiatric problems, but it's been thought about.
Mad Hatter, right?
Right, exactly, Mad Hatter.
It felt, which was stiffened by mercury.
Exactly right.
And all these hatters got crazy.
And maybe we're turning into Mad Hatters, I don't know. But we're exposed to mercury at a lower level, but it's still neurotoxic, so that has to be assessed. And then I talked about the endocrine disrupting chemicals. It's massive. There have been over 1,300 studies on endocrine disruptors, and clearly, since they're endocrine disruptors, they affect the brain. Right.
And we've been talking about this for decades in functional medicine. I just saw a paper come out this week in the Journal of the American Medical Association on endocrine disrupting chemicals and our massive exposure, the grandfathering in of so many of these chemicals into our food supply, into our body care products, into household products that have never been really adequately tested.
I mentioned briefly in the lecture about how it's a tributyl tin is what it's called, and this is put in paints so that the paints don't have a foul smell. And it shows up in seafood, and it's now shown that it dissociates the hypothalamic CRH stimulus which sends a message to the pituitary to release ACTH, it actually dissociates that stimulus. So your brain is saying, come on, give me more, ACTH, but the pituitary is not responding, right? And that's
how does a fish get the?
I guess it's from dumping and going into the the common
They're not
pool.
eating paint chips. So I want to sort of digress to another topic, which is the microbiome, because you alluded to it in your talk, and we never thought that the gut flora could play a role in mental illness, right? And I think in functional medicine, we've clinically observed for decades that when you fix people's gut, their mood gets better, their depression gets better. Never quite understood what was happening. We've seen studies where antibiotic use has been linked to depression. We've seen studies on sort of irritable bowel, where it may be not that we always learned in medical school that these patients were anxious and had psychiatric issues, which is why they had irritable bowel. But it may be that the irritable bowel is causing an irritable brain, not the other way around.
Or both ways.
Or both, bi-directional. So the question is, what is the emerging evidence around the microbiome and gut health on the brain and depression and psychiatric disorders?
So there's a lot of evidence that there's a linkage. There's no question of linkage, and there's no question that the linkage goes both ways, that is bidirectional. As I mentioned, we're not at a point where we can say, take these specific species of probiotics and your mood will get better. And that would be the same as saying, take this particular drug for your mood. That's too reductionistic. But we do know that by having a diverse microbiome and correcting the gut and reducing the inflammation from there, that we're affecting the neurochemistry in the brain, which relates directly to psychiatric disorders and depression. So it's really about having a diverse microbiome and correcting deficiencies in pathogenic bacteria and organisms in the gut, and strengthening the barrier, the gut immune barrier, and through all the methods, we talk about diet and supplements and et cetera. And that clearly takes a layer of inflammation out of the body, thereby helping the brain. So I haven't seen, maybe you have, but I haven't seen a study that says, let's take 100 patients with depression and treat their gut and see how they do. But I am sure that we would see a significant improvement. Would that take the depressed patient all the way to recovery? Maybe not. But would it improve a significant layer? For sure.
That was really important, I think, as a take-home in your talk, which is that when you did your case studies, it sort of reminded me of Dale Bredesen and his 36 holes in the roof model, where you didn't just correct methylation, you didn't just correct the thyroid, you didn't just correct the adrenals, you didn't just correct the gut flora, you just didn't deal with infections. You dealt with all of it.
That's what you have to do.
You deal with all of it, and you do it sequentially, and you do it in the right phases and steps. But you showed, over 10 months, you took people from really treatment-resistant depression to recovery without any change in medication.
That's right. And it's a regular occurrence. I mean,
it's not an anomaly.
I'm a psychopharmacologist. I was certified as a psychopharmacologist, but I have slowly actually learned that I don't need to do much in psychopharmacology anymore.
Do you take people off medication?
I take people off medication. I treat patients with bipolar type 2, the milder form of bipolar 2, without medication, successfully, routinely. If someone comes in with a severe depression and they need medication, that's fine, use medication, but get moving on these other things. Do a complete history.
So it's a bridge to when you get all this other stuff cleaned up.
If you have to have that bridge, you use it. I am not against the meds. I'm against complete reliance on them, and we know from the data now that their efficacy is limited.
And polypharmacy, there's no evidence on polypharmacy, right? There's no evidence of applying 4 or 5 drugs in patients.
The STAR-D study shows a very small increase in the number of people who remit from their depression when you use polypharmacy, but it's a very small, the juice isn't worth the squeeze, really.
But we talk about evidence-based medicine, but when you really look at, combining all these various medications in psychopharmacology, there are no clinical trials combining 3, 4, or 5 medications in patients, seeing how they do, which ones to combine. I mean, there's no evidence around that.
The evidence is that in the STAR-D, where they combined different medications, that
there was a little bit of improvement, but it wasn't like, should you apply this one and this one and this one? It was random.
The theory is different mechanisms, right?
Right.
And that's the theory, but that's not proven, really.
Right. Yeah. So I think when we talk about evidence-based medicine, I think the emperor has no clothes here.
This is, unfortunately, it's pretty disturbing.
So, I want to also talk about micronutrients, because I think you mentioned a few things around that I thought were interesting. One was that, we often miss by not looking for common micronutrient deficiencies: zinc, copper-zinc imbalances, methylation problems, iron deficiency, magnesium deficiency. You mentioned calcium deficiency. There's others for sure. So, and the one thing that I remember reading a number of years ago is that in women who are over 65 and who are depressed, 25% of them had a methylation issue with either inadequate B12 or folate that wasn't measured typically with a folate measurement, or even a red cell folate, or even a B12 level, and that you had to look at other indicators. And typically we look at homocysteine and we look at methylmalonic acid, but you were challenging the wisdom in functional medicine of using methylmalonic acid as a biomarker for B12. Could you talk about that a little bit?
Yeah, I mean, I was using methylmalonic acid myself, and I actually never saw much benefit to it, and I did some research.
And you didn't see frequent elevations of it? Or?
No, I didn't. But everybody was using it, and so I was looking. But I found this paper that I alluded to. I think it was in Clinical Chemistry in 2008. And what they found is they could only account, based on known biological pathways, they could only account for 17% of the variation in methylmalonic acid. Out of that 17%, B12 actually only accounted for a small portion. So the methylmalonic acid level is determined by many factors we don't know, and B12 is a small factor there. Therefore, measuring MMA is not really clinically useful.
Neither is B12 levels, though.
I think neither is B12 level. That's why I said you need to look at...
So what's a doc to do?
You look at the CBC, look for anemia, look for MCV. Is it large? Make sure it's not being, the macrocytosis is not being masked by an iron deficiency or other causes of macrocytosis. Look at the homocysteine, MTHFR SNP if you can do that. Look at their age. As you get older, you need more B12. You have trouble absorbing it. The parietal cells don't make intrinsic factors.
Although people's levels are less than 500, there's probably an issue, right?
But yes. I would say if their level is 600 or 700 and have a neuropsychiatric problem, there's probably an issue.
Yeah, so maybe there's false negatives, but very few false positives, right? If it's low, it's low.
But where the range is, I believe the lower limit is like about 280 or something.
Yeah, well, you're screwed by that.
And you're like, no, please don't go by that.
Well, what people don't realize is that those typical lab tests are usually 2 standard deviations from the mean in a large population, whether you're 2 years old or 92.
Right.
And so really maybe we need to shrink them to 1 standard deviation. Yeah.
And move it up.
Move it up.
With the B12, I'd say you got to move it up for sure, because I've seen it clinically. And if you do this dynamic assessment, in other words, dynamic in your mind, imagining the microcytosis, the macrocytosis, where's the homocysteine, where's that methylation cycle, what are the medications, how old is the patient, do they have a bacterial overgrowth of the small intestine, what are all the factors related to B12, and then they have a neuropsychiatric problem, it's pretty safe to give B12. Now, if you're going to give massive doses over a long time, we don't know what that does. But it's pretty safe as a trial to see if people...
And I often see doctors patients who are supplementing B12, their levels will be high.
Right.
Because the reference ranges are for unsupplemented.
Right.
And so the doctors say, oh, you're B12 toxic, stop the B12.
Stop the B12, but it's not intracellular either. Right.
And it's also water soluble, it's not toxic, and the levels, Yeah, it's great. So are there any other pearls of wisdom that you want to share around functional medicine, psychiatry?
Yeah, I mean, another pet peeve of mine is the thyroid. Okay, so it's a big deal because it has a major effect in psychiatric problems. So the NHANES study I referred to said that the mean TSH in this country is 1.5. And that was a study of 16,500 people. So a clinician who's looking at someone with depression really needs to look at the TSH, look at the free T3, look at the free T4. I like the reverse T3. I know endocrinologists think that that's not, they even feel that free T3 is not relevant. The free T3 in the body doesn't necessarily reflect what's going on in the brain. The brain actually modulates T3 pretty well on its own, but we don't have measures for that. So I'm very careful. I want the TSH to be 1.5 or a little lower. I want the free T3 to be in the middle of its range, and obviously that's in concert with physical exam and symptoms, and I think that's critical. And the last thing I'll say is that there was a large study of over 17,000 people that looked at the risk of fractures and atrial fibrillation in elderly population over 65, right? And this study showed that they looked for what's the TSH that normalizes the risk of AFib and fracture in this older population. So you would think it'd be like 1.5, right? Turns out that the risk of AFib and fractures actually normalize if your TSH is subnormal at 0.04 to 0.4.
Wow.
This is a huge study.
That's amazing.
So you have to, I'm not saying hyper,
although if you treat people with a bioidentical thyroid, their TSH is always suppressed because the T3 is the feedback loop. So if you're giving T3, it'll cause the suppression, of the TSH. So often doctors say, oh, your TSH is too low, but if you look at the T3 and 4.
But you do want to watch, make sure they don't develop AFib, and watch the DEXA scan if they're on long term. But I'm saying there's leeway.
Biomarkers of urinary absorption.
And I'm saying there's leeway in depression to push the TSH below 1.5.
Yeah.
Frankly, I want the TSH, again, within the context of symptoms, below 1 if I'm treating a treatment-resistant depression. And I want that free T3 to be in the mid-range.
What I find fascinating is that, in traditional endocrinology, they don't really treat with T3, and they often will be very concerned about giving T3. And yet in psychiatry, it's often one of the sort of tricks in the bag that they use for treatment-resistant depression is T3 even in the face of normal thyroid, which I find fascinating.
Well, remember the 5-HT1A receptor I showed you? You need that T3 to help the receptor function, but obviously many other functions to thyroid hormone. But it does seem to work. But I would, if I had someone with completely normal thyroid functions, I don't really use thyroid to augment. I look for the other causes.
Yeah, of course. And often, people's adrenals are not working, their thyroid's not working properly, and if people have thyroid antibodies, they may not have abnormal thyroid tests, but they're actually, not functioning it properly. So it's really interesting. So basically, mental illness is often resulting from changes in the matrix, inflammation, changes in the gut flora, microbiome, nutritional status, macro and micronutrients, toxins, hormonal imbalances, adrenal thyroid issues, stress. All these factors are modifiable through understanding how to work with the matrix and use the lens of functional medicine to identify the unique causes. Because if you see, 10 patients with depression, they might have 10 different causes. And I always say because we know the name of the disease doesn't mean we know the cause.
It's just a syndrome.
It's a syndrome, right. And I think, that's the Sidney Baker model of name it, blame it, and tame it. You name the disease. Oh, I know why you're sad and hopeless and helpless. You have depression. That's why you feel like that. No, it's just the cause, the name we give to people who share those symptoms. And there could be dozens of causes.
That's right, and there are.
And in each individual, it's quite different. So what you're saying is there's no one size fits all for using functional medicine. It's basically looking at that individual, doing a thorough history, doing the right diagnostics, figuring out where the issues are, and then targeting those problems.
And when you do that, not only are you helping their mental health, but you find that the comorbid conditions...
Everything else goes away.
Everything else goes away.
You can't just treat the brain, you treat the system,
the whole body.
And then everything else goes better.
That's right. That's right.
Great. Well, welcome to Cleveland Clinic, and thank you
for having me.
For being here and sharing your wisdom of decades of knowledge. And Bob and I, we actually were in the same graduating class at the Applying Functional Medicine Clinical Practice back in the 90s. And here we are today at Cleveland Clinic.
Fabulous.
Thank you, Bob.
Who knew?
Thank you, everybody, for joining us. And we're going to be doing Grand Rounds again, Functional Medicine Grand Rounds, December 13th. Mark your calendar with Dr. Alessia Fasano from Harvard, who's world's expert in gluten and non-gluten non-celiac gluten sensitivity, as well as leaky gut and autoimmune disease. So it's going to be a fascinating conversation we'll have with him, Grand Rounds as well, and I look forward to seeing you there.